Hello everyone, myself Dr. Prateek. So today we will discuss about facial nerve anatomy. So what do you mean by facial nerve? It's a seventh cranial nerve. It's a mixed nerve. Why mixed? Because it consists of motor, sensory as well as parasympathetic fibers. It's a cranial nerve which is seventh in number. So where does facial nerve arises? It arises at the level of the pontomedullary junction. Now look at this slide. Firstly, we have discussed it's a seventh cranial nerve, which is a mixed nerve. It consists of total 10,000 nuclei, out of which the 7,000 nuclei are motor and 3,000 nuclei are sensory. As you can see, suppose this is my pontomedullary junction. So these 7,000 nuclei will form the motor root. It will take a turn around the abducens nuclei, that is a sixth cranial nerve, and then it joins with the sensory root. So this forms my complete facial nerve. Then while exiting from the pontomedullary junction, it enters into internal auditory canal. And this internal auditory canal is a part of the temporal bone. So then after entering into the internal auditory canal, it gets exit, forms the first genu, and then enters into the middle ear, and this forms the horizontal part in the middle ear. And this forms the vertical part in the middle ear. And this vertical part then get exit from temporal bone through stylomastoid foramen, and this stylomastoid foramen, after exiting from this foramen, facial nerve gives multiple branches to various muscles. So this is how we can divide this facial nerve course into three sections. The first section is intracranial, which is starting from the pons or medulla junction and until the level of entry into internal auditory canal. This is my intracranial portion. And then comes my intertemporal portion, that is with the entry into internal auditory canal till the level of stylomastoid foramen. This complete is into the temporal bone, so this is known as intratemporal part. And beyond that, that is my extratemporal part, that is outside of temporal bone. Now, this sensory root, it is known as nerve of nervus intermedius, or also called nerve of Risberg. Why I am saying this? It has been asked in the exam. The sensory fibers in the facial nerve, that is known as nervus intermedius or nerve of Risberg. And what happens in central facial palsy? What do you mean by central? If the lesion is at the level of central fiber or at the level of the cortical fiber, okay, then in central facial palsy, my forehead will be spared and rest of the face to the concerned side would be paralyzed, or there will be paralysis. Why the above forehead is spared? Because we all know the fibers, the cortical fibers, they just cross each other. In the brain, what happens? The fiber from the left side, they goes into the right side, fibers from right side goes into the left side. So if there is a central lesion over the one side, so it also gets supplied from the opposite side. That is the reason the forehead will be spared in the central facial palsy. Again, examination point of view, it is important, asked in the exam. Now, here in this presentation, what I prefer, I'll give you just the visual pictures without giving much theory. So my aim is to make you guys understand how this facial nerve takes a path, how the branches are emerging, and how their pathology will affect the various symptoms or various signs. So look at this diagram. This is my seventh cranial nerve, which is known as facial nerve. You can see this is my pons medulla junction. You can see this is my part of the brain, as you can see, and this is my pontomedullary junction. So this is how this facial nerve get arise. This is intracranial part, and from there it enters into internal auditory canal. You can see a circle here. I'll mark it in the red. You can see this is my internal auditory canal. And this is how this facial nerve will enter into IAC, that is a part of the temporal bone, and then it goes inside, take a U-turn, that is known as first genu. From this first genu arises the greater petrosal, now GSPN, greater superficial petrosal nerve, GSPN. Here you can see this white structure. This is the bone shown as the temporal bone, and you can see after entering into IAC, going towards going into the temporal bone, taking a turn which is known as the first genu, it gives a branch which is known as GSPN, greater petrosal nerve, and then it enters into the middle ear like this, makes a horizontal course, and then it takes a vertical turn. So this is known as horizontal to vertical, my second genu, and this is my first genu. Okay, and then it exits from the stylomastoid foramen. You can see here, this is my stylomastoid foramen. So this, starting from this level until the level of this stylomastoid foramen, this is my intratemporal part of the facial nerve, and it exits from the stylomastoid foramen and gives various muscular branches, as you can see. Now, in the temporal bone, we all can see the facial nerve is giving three branches. The first one is the GSPN. This is my first branch. The next one is nerve to stapedius, which supplies the stapedius muscle attached to the stapes bone. And the third branch is chorda tympani nerve. Now, let's look at the GSPN now. This GSPN now, how does it course? So it goes ahead, enters at the level of the foramen lacinum, then it makes relay in the pterygopalatine ganglion. You can see this is a ganglion which is known as pterygopalatine ganglion. So this GSPN will make a relay center, or it just relay in the pterygopalatine ganglion, and from there it supplies to lacrimal gland, nasal mucosal glands, and oral and pharyngeal mucosal glands. So this part is basically secretomotor fibers, as they are helpful in secretion of the mucosa into the nose, oral cavity, pharynx, and also responsible for lacrimation. Okay, and this also carries sensory fibers from the soft palate. So the sensation from soft palate are also being carried away by the facial nerve, its branch known as GSPN. Now let's talk about nerve to stapedius, which supply the stapedius muscle, and you all know that this stapedial muscle, when it contracts, it's help the inner ear getting destroyed or destroyed or any injury whenever there is a loud sound, because it restricts the extreme vibration of the stapes bone, and thus helping the inner ear protection from loud sound. Okay, the third nerve is chorda tympani. You can see this is my chorda tympani nerve, which is going through the petrotympanic fissure, and then firstly this chorda tympani, it carries taste fiber from anterior two-thirds of the tongue. Anterior two-thirds of the tongue, these taste fibers are being carried by the chorda tympani nerve. Plus, this chorda tympani, it is also carrying secretomotor fiber to submandibular and sublingual glands. So here you can see this is making a relay at the submandibular ganglion, and then providing the secretomotor fiber to submandibular and sublingual glands. So this is the function of the facial nerve. This chorda tympani is helpful in secretion of saliva from submandibular or sublingual salivary gland. There is a difference between production and secretion. This chorda tympani just secrete the produced saliva from the salivary gland. It doesn't produce the saliva. So whatever the saliva is being produced in submandibular and sublingual salivary gland, through these secretomotor fibers, the saliva being secreted through these glands, and it carries taste sensation from anterior two-thirds of the tongue. Now tell me, posterior one-third of the tongue, which now is responsible to carry the taste sensation? The answer is glossopharyngeal nerve, that is the ninth cranial nerve. Okay, so anterior two-thirds facial nerve, posterior 1/3, glossopharyngeal nerve, and talking about the taste sensation from the tongue. I hope anatomy is little bit clear how it enters from the brain into the internal auditory canal, then going into the middle ear, exiting from the stylomastoid foramen and giving various muscular branches. I discuss you, there are 3 branches in the temporal bone. First one is greater superficial petrosal nerve, responsible for lacrimation, the mucosal secretions in the nose, oral cavity, pharynx, etc. Next nerve is nerve to stapedius, and the third nerve is chorda tympani nerve. Another simplified diagram just to make you understand about the anatomy of facial nerve. Now look at this diagram. This is my central compartment of the facial nerve, where we can see the fibers are crisscross. The fibers are going from one side towards opposite side. So that's the region. Suppose my pathology at this level, this is my central lesion. So some of the fiber from opposite side will goes and form the facial nerve. So suppose lesion is this side, that is my central facial nerve lesion. So my forehead will be spared because it carries now fiber from opposite side also. And suppose if the lesion is at this level, where both the fiber already decussated or they're from the facial nerve. Now, if the lesion is this side, so complete half of the face will be affected. Okay, getting what do you mean by upper motor neuron lesion and lower motor neuron lesion? Suppose this is my LMN and lesion is upper, then that is known as upper motor UMN. Okay. So in upper motor neuron lesion, forehead will be spared of one side and the rest of the face will be paralyzed over that side. But in lower motor neuron lesion, complete half of the face towards same side will be affected. Okay. Now look at this facial nerve. This is my abducens nucleus, as in the center you can see. Okay. So this facial nerve motor fiber will taking a turn at the abducens nucleus and mixing with the sensory fibers, that is the nervous intermediates, and entering into the internal auditory canal. So this is my temporal part, and then they run into internal auditory canal and exit through this IAC, internal acoustic meatus, and internal auditory canal. Then they take a sharp turn to form the greater petrosal nerve, and this sharp turn is known as geniculate ganglion. That is the first genu. It is known as first genu of the facial nerve. So I told you this GSPN function. Then this facial nerve will run into the middle ear, takes a horizontal course, which is known as horizontal part of the facial nerve, and again it takes a U-sharp turn, which is known as second genu of the facial nerve, and then it runs vertically, giving the branches chorda tympani or the nerve to stapedial nerve and chorda tympani, and then it get exit from stylomastoid foramen and giving terminal branches while running into the parotid gland. These branches are like frontal, ophthalmic, oral, and etc. other branches. We will discuss everything. Okay, so I hope this much part is clear. This part exiting from the stylomastoid foramen, this is extratemporal part. From internal auditory canal till the level of the stylomastoid foramen is the intratemporal part. Now, so let's discuss about intratemporal part, which is the facial nerve goes into the temporal bone. So there are 4 parts. First one is the meatus, that means the facial nerve running in the internal auditory canal. So that is known as the meatal part. Then after exit from the meatus, it takes a sharp turn, which is known as the first genu, and enters into the middle ear. So that much part is known as labyrinthine part. The third part, which is known as tympanic part, is the horizontal part of the facial nerve in the middle ear. That is tympanic part. And then again it will make a sharp turn to form the second genu, and then it runs vertically into the mastoid cavity, which is known as vertical part. So in temporal bone, it has 4 parts. Now first one is the meatal part, that is the part into internal acoustic canal, internal auditory canal. So first part, it is around 8 to 10 mm long. Okay, and the meatal part, it is supplied by the labyrinthine artery, and this labyrinthine artery is a branch of anterior-inferior cerebellar artery. So labyrinthine artery is a branch of anterior-inferior cerebellar artery. Now comes the labyrinthine part. It is the narrowest part and the shortest part. It is around 3 to 4 mm. And again, asked in the exam, the shortest and the narrowest part of the facial nerve is labyrinthine part, which is around 3 to 4 mm, and this is the part which is most commonly compressed in any viral infection, because it's such narrow. Any infection with a slight edema will cause a compression over the facial nerve. So in any viral infection like the herpes zoster, you can say, or any herpes simplex or anything, the most common part of it is the labyrinthine part. And this part again is supplied by the labyrinthine artery. Just try to remember the inner ear, the facial nerve in the internal auditory canal or the labyrinthine part. These all are supplied by the anterior inferior cerebellar artery branches. And this facial nerve part are supplied by the labyrinthine artery. But AICA, anterior-inferior cerebellar artery, is the artery responsible to supply the inner ear or related branches. Now in the middle ear, when this facial nerve enters, the part known as the tympanic part, which is around 11 mm. And this is the site for dehiscence, because mostly naturally the facial canal is dehiscent in the horizontal part, that is tympanic part. So it is most common site of dehiscence. Again, examination point of view, it is important, asked in previous years. Now, this tympanic part is supplied by the superior petrosal artery, which is a branch of middle meningeal artery. We know the middle meningeal artery giving supply, the blood supply to the middle ear. Just try to recall the middle ear blood supply. So from the anterior wall, the branches from the middle meningeal artery enters. So tympanic part will be supplied by the middle meningeal artery branch, that is superior petrosal artery. And then comes the vertical part, which runs into the mastoid. It is the longest part, 13 mm long, and it is supplied by the stylomastoid artery. Just try to remember, vertical part, the facial artery exit from the stylomastoid foramen. So the blood supply will be stylomastoid artery. That is a branch of the posterior auricular artery. Now again, one simplified diagram just to show how many fibers are in there in the facial nerve. So this red one is the motor fiber, or we can say efferent. Okay, so this red one is the motor fiber, and if we talk about the blue, that is the sensory fiber. Okay. You can see here sensory. Then yellow one is the parasympathetic fiber. This yellow is parasympathetic. Okay, already it's marketed. So let's see these motor fiber in the facial nerve. They are going inside, making the first genu, that is a geniculate ganglion, and giving the first part, that is a GSPN nerve. This is GSPN. And in this GSPN, you can see the parasympathetic fibers are there, which are marked in the yellow color. And these are the secretomotor fiber, which relay in the pterygopalatine ganglion and then supply to lacrimal gland, nasal gland, etc. And thus helps in secretion of the these tears in the eyes. So that's the reason any facial nerve lesion or pathology will lead to dryness of the eye, because there will be less lacrimation. Okay. Now, as you can see, the motor fiber, they are going inside the first branch, first part, motor fiber. They are supplied to nerve of stapedius, so helps in stapes muscle contraction. And then further, they are giving the auricular branches, stylohyoid to digastric branches, and to the facial muscles in the parotid gland. We all know the 5 structure. I will tell you. So these are the motor fiber, and then comes the sensory fibers. So what does these sensory fibers? They just go, and they firstly the sensory fiber, they go with the chorda tympani. This is my chorda tympani now. Okay, and from this chorda tympani now, so firstly they will relay in the submandibular ganglion, and then they will supply to the submandibular sublingual gland and helps in secretion of saliva. So this facial nerve lesion, what will cause? Dryness in the mouth, because there will be less salivation. And tongue, it carries the taste sensation from the anterior 2/3 of the tongue. So I hope, just to simplify with the help of the diagram, so I hope the facial nerve anatomy you are getting more easier. Now let's discuss about the branches. I told you intertemporal part, there are only 3 branches. The first branch is GSPM, greater superficial petrosal. Second is nerve to stapes, and third is chorda tympani nerve. And suppose this nerve to stapes got injured, what will happen? I told you, so stapes bone will be whenever there is a loud sound, so it will be more vibrating, and these vibration will directly get transmitted into the inner ear. So this may damage the sensory part of the inner ear, that is the outer hair cell, we can say, or the part responsible for the hearing. Okay, so these are sensory neuroepithelia may get damaged. So that's why facial nerve plays a protective role also. Okay, and this chorda tympani for the taste sensation and for the salivation. Extratemporal part of the facial nerve. The first branch, while exiting from the stylomasted foramen, it gives the auricular branch. We all know in the external auditory canal, we all know the posterior superior part is being supplied by the facial nerve branch. Okay, so it gives muscular supply to the auricular branch, then nerve to stylohyoid muscle and the digastric muscle. See, this is my mastoid bone. Suppose this is my mastoid bone and this is my mastoid tip, and anteriorly here comes the EAC. This is E, external auditory canal, and beyond that, beneath that, there is a mastoid bone. So this is my mastoid tip. This is my tip, and at this mastoid tip, over the medial side, that means towards the body, this is my lateral side, and if I go inside, that is the medial side. So medial side, the digastric muscle is attached. Okay, so this digastric muscle is being supplied by the facial nerve. And what are the terminal branches? When it exits from the stylomasted foramen and then enters into the parotid gland substance, it gives 5 branches. What are the 5 branches? Let's put your hand over the face. So first branch is temporal. Okay, as it is going over the temporal. The next branch is zygomatic, and third branch is buccal, over the buccal cavity. Fourth branch is mandibular, because it is running over the mandible, and the fifth branch is cervical, going in the neck. So 5 branches: temporal, zygomatic, buccal, then comes the mandibular, and comes the cervical branch. Now, again important point, surgical landmark for the facial nerve. So look at this diagram in the middle here. It is surgically also important, and examination point of view very important. So there are multiple surgical landmark. The first one is processus cochleiformis. So what is processus cochleiformis? It is a bony projection. You can see here. This is my processus cochleiformis. So the facial nerve, or we can say geniculate ganglion, that is the first ganglion, lies in front of it. What is the correct position? Anterior and superior. So this is processus cochleiformis. So the first genu, it is lying anterior and superior to it. So again, this is a surgical landmark. The next landmark comes a lateral semicircular canal and the oval window. So you can see this is my oval window and this is lateral semicircular canal. So facial nerve is running in between lateral semicircular canal and oval window. So it represents again a surgical landmark. The third landmark is short process of incus. So whenever we open up the mastoid cavity, suppose this is my external auditory canal and this is my mastoid cavity. Okay, so what happens whenever we drill at this area? Whenever we drill at the mastoid area, we drill at this area. So once we reach the antrum, we can appreciate the short process of incus. So just try to find out the short process of incus. Facial nerve is immediately medial to that. So it again serves as a short process of incus, serves as a surgical landmark. The facial nerve is very important whenever we are doing the posterior tympanotomy technique or the facial nerve decompression surgery. So it serves an important landmark. The fourth landmark is the digastric ridge. So I already told you at the mastoid tip over the medial side digastric muscles are attached to the mastoid bone. So this form a ridge. So facial nerve is always medial to this digastric ridge. And whenever we are doing the superficial parotidectomy, so again this digastric ridge will serve as a landmark, because suppose we have given incision for the superficial parotidectomy, so we just try to find out the digastric muscles insertion into the mastoid bone, and once we look at the digastric ridge, we know that facial nerve will be medial to that, not lateral to that. And last landmark is the cove. Cove is again a bony projection, or we can say bony ridge. Now, topo diagnostic test. Many times examiner has asked the question about these topo diagnosis. So he will frame the question like the patient is having the loss of the lacrimation, loss of the saliva and everything. So tell us about the site of lesion of the facial nerve. So to understand this, firstly we will draw the facial nerve diagram. So we all know, suppose this is my internal auditory canal. Okay, so this is my IAC, and how this facial nerve runs. So after emerging from the pontomedullary junction, this facial nerve enters into IAC, then forms the first genu, and then takes a horizontal course, again form a second genu, and then runs vertically, and then exiting from the stylomastoid foramen, and then gives multiple branches into the parotid gland. Understood? This much we have understood. This is stylomastoid foramen. Stylomastoid foramen. And this is my first genu. Okay, I need to. So this is, suppose, my first branch, that is the GSPN. And then comes my second branch, that is the nerve to stapedius, and then comes my third branch. Third branch is chorda tympani now. Okay. Now this is a very simple diagram. Just try to recall everything. So suppose Schirmer test. Schirmer test is basically done to check about the level of the lacrimation in the eye. What we do, we will use a paper. What kind of paper? You can say there is a tissue paper. You can use a tissue paper, litmus paper or blotting paper are there. So what we'll do, we'll put the paper into the eye over the lateral fornix of the eye towards the lateral canthus. Inferiorly, we'll put a strip of the paper and we will look how much wet it goes. How much wetting is there as compared with the examiner or with the normal eye. So it should be wet properly. That is suggestive of the proper lacrimation is there. So suppose my lesion is suprageniculate. What do you mean by suprageniculate? Suprageniculate, it means my lesion is at this level, above the level of the first genu. That is a suprageniculate. So just we will understand. Suppose my lesion is suprageniculate. So what will happen? All the three branches will get paralyzed. Understood? Suppose my lesion is at this level, so this will get affected, GSPN, nerve to stapedius, chorda tympani, and all muscular branches. So every function will be lost. Got it? Simple. If the lesion is suprageniculate, suppose at this level, so this much now, the nerve beyond this, I mean now before this, will be normal, but all the branches are after this first genu or at the level of the first genu. So if lesion is suprageniculate, every function of the facial nerve will be lost. Understood? Suppose my lesion is after first genu, that is infrageniculate. So what will happen? All the structure, all the nerves like stapedial function will be lost. Taste sensation from the chorda tympani or salivation from the submanual gland will be lost, and these motor fiber will be lost because any pathology at this level. So after the facial nerve part, after this the function will be lost. And before this is lies a GSPN will be still functioning. So if the lesion is my infrageniculate, we can say that is after first genu, so only the lacrimation from the eyes will be normal, the mucus secretion from the oral cavity, pharyngeal cavity or nasal cavity will be normal, but now to stapedius, chorda tympani or the motor branches function will be lost. Again, if suppose my lesion is after now to stapedius, again very much simple. So these two nerves will be spared. So function of nerve to stapedius and GSPN will be preserved, but the portion of the facial nerve distal to the stapedius nerve will be lost. So chorda tympani function will be lost. And suppose my lesion is at the level of chorda, stylomastoid foramen. So all these three branches function will be preserved, but these motor supply to the facial nerve function will be lost. This is very simplified. Now try to understand looking at this topodiagnostic test. Now Schirmer test. So what is the Schirmer test? In suprageniculate lesion, that means the lesion at this level, so Schirmer test, the lacrimation will be decreased or lost. So this test will be negative. Okay, but if the lesion is suprastapedial, that is above this level, at this level, or infrastapedial or infracaudal, that means level below than that. So in these cases, GSPN is still preserved. So lacrimation will be affected only when the lesion is at level of suprageniculate. Very simple. Just try to recall this diagram. Just try to make a diagram in your mind, or whenever examiner want to ask such questions, just draw a diagram over the rough paper, and you can easily solve each and every question without getting any wrong answer. Now suppose if we talk about the stapedius reflex. So if my lesion is suprageniculate, that means at this level, first level, so again every function will be lost. So this is negative here. If my suprastapedial, again negative. If my lesion is infrastapedial, that means at this level, infrastapedial. So now to stapedius is preserved. So stapedial reflex will be preserved. So again we can see in all other lesions like this. If we talk about the motor fibers, so motor fibers are the terminal branches. So any pathology above than that, any facial nerve lesion above than that will definitely result in motor loss, because the fibers are coming from upside now, from the starting. So if there is pathology above than that, so all the motor function will be lost. So that's how you can solve each and every question. I hope this is clear.